Today we're going to talk about it's Valentine's Day, so kind of a weird day to do it, but it's how it landed on the schedule. But we're going to talk about the Ohio Domestic Violence Network protocol for healthcare providers. So this was originally developed in 2003 and then revised again in 2012. So some of the stats are out of date in the protocol itself, but I did try to pull in some more recent stats from the CDC and several other websites, which I included in the citation list. But there is a healthcare provider's standards of care for those who interact with and treat individuals who might have been the victim of domestic violence or interpersonal violence in Ohio. I decided to do this topic because the issue of what to do if somebody is a victim of if an adult who is not developmentally disabled, is their own guardian, is not elderly, so kind of your standard average adult, what to do and what are the reporting requirements and limits to confidentiality or projections around confidentiality. This conversation comes up with students a couple times a year, I feel like. And in digging into it a little bit more, I realized that things, what the limits and restrictions on confidentiality are a little bit different depending on your setting and profession. So we're going to dig into that. So domestic violence, interpartner violence is a pattern of coercive, assaultive behaviors against anybody that's a family or household member or an intimate partner. So somebody with which a person is in a dating type of relationship. It includes physical, sexual, psychological attacks, as well as economic coercion. Big characteristics around these types of violence are isolation, intimidation, and coercive control. I put the Ohio Revised Code in here because it is important to look directly at the Ohio Revised Code when knowing the limits and restrictions around reporting versus maintaining confidentiality. But these acts against a person, the coercion, the intimidation, are intentional and they cause the target of the attacks to experience intense fear, helplessness, sometimes hopelessness, loss of control, potentially feelings of threat of death, or to kind of sum it up more clinically, trauma. So these are all intended to and do cause a great deal of trauma to the victims. So this is a power and control wheel, which you can find in the actual domestic violence protocol, which I posted a PDF of on IECHO. And it was created by the Domestic Abuse Intervention Project in Duluth. But it's important to look, when you're looking at the various examples here of the different types of power and control and your physical, sexual, emotional violence, is that this was developed to really look at and help understand the lived experience of a woman living in a domestic partnership with a man who is abusive. So it's not going to be fully encompassing of all types of relationships and all types of power dynamics. It's something to point to, but it's not going to be fully representative. And that's important to keep in mind, but it is a nice tool. So rates in the US of domestic and intimate partner violence are pretty high, far more women than men. But the current rates are that it's estimated that every 32 minutes, somebody is the victim of domestic violence in the US. That turns out to be 16 million people per year, 85% of which are women. And I will note that this is reported violence. I am of the belief that domestic violence is underreported across the spectrum of genders and sexes, potentially far more underreported for men than it is for women. Lifetime prevalence estimates are 1 in 2 women and 2 in 5 men will experience some type of domestic violence. And over 61 million women, 53 million men report having experienced some type of psychological aggression in their life. Over half of female homicide victims are killed by either a current partner or former partner. And women who have been victims of domestic violence actually, so this kind of relates to the bigger picture of healthcare, are more likely to report having asthma, diabetes, and irritable bowel syndrome, in addition to the spectrum of mental health effects that you would cite. There are also high rates of pregnancy and unplanned pregnancy when it comes to domestic violence. So, adolescent females who report being in a violent or abusive relationship are 4 to 6 times more likely to become pregnant than adolescent females who are in a nonviolent relationship. Annually, around 5% of rape survivors will become pregnant as a result of the rape, and 50% of which historically have chosen to access abortion. And 40% of pregnant women in violent relationships report that the pregnancy was unintended, compared to only 8% of women in non abusive relationships reporting those as unintended pregnancies. So the protocol is outlined in the document, is kind of a multi-stage thing. So it's prepare, screen, assess, intervene, and documentation. So under prepare, and within every stage of this, we want to maintain a trauma-informed lens. So that is incredibly important to stay trauma-informed. With trauma-informed kind of as a universal precaution of knowing that anybody in front of us at any given moment could be the victim of trauma. They might have experienced trauma, and we might not know the extent of it. They might not disclose the extent of it. So we want to take an approach that does our best to minimize any risk of further harm, whether or not we know that that harm or history exists. So under prepare, it's really about preparing yourself and your environment. It's knowing what the local documentation reporting requirements are. And I wrote local, but it's usually statewide. So everything that I talk about today is under the Ohio law, but if you practice in a different state, it is going to be different. To prepare yourself, you want to understand the impact that domestic violence has on victims and families, from the physical aspects to emotional aspects, health aspects, and economic financial aspects. Be familiar with local resources, both at the state and community level, and try to create a safe, welcoming environment. So that's could be things like posting informational flyers in a lobby, wearing pins, anything that gives your patients the sense that you are open to talking about it in a non-judgmental, safe way, and that helps them to feel kind of safe and respected in being able to talk about it. Under screening, it's recommended to do universal screening, and not just one and done, but universal annual screening. So if you make it a point that you're screening everybody with some basic questions, then it really reduces the stigma. And it's not about like, well, why are you asking me questions? It's, well, we ask these questions to everybody because we want to be sure that everybody is safe and be able to provide resources for anybody who feels unsafe. You should really screen alone. People are unlikely to disclose abuse if they're with somebody else in the room, whether that person is the abuser or another family member that they just don't want to talk about it in front of. One of my favorite examples of this is anytime that my husband has been in the hospital, they do a screening, a couple screening questions the nursing staff would do, and do you feel safe in your home? And he routinely makes a joke about me sitting directly next to him, which is valid, because if he didn't feel safe at home, frankly, you're asking with another person in the room, will that person feel safe to answer that, if they're not alone? You also want to explain why you screen everybody and what you do with the information. And this is a space that you may need to explain confidentiality, all of the things that it does protect, and where the limitations exist. So in assessing if a person does disclose some type of violence, you need to assess the threat to their immediate safety and overall degree of violence or injury. Looking at things like, has it escalated? Has it escalated over a certain period of time? Are there people in the household at risk? Is there accessibility to firearms? How is the individual coping with the violence? This could dive into things around linkages to substance use disorder, potentially mental health strategies. There's lots of things that this could encompass, but there could be, and depending on the setting, the assessment might be, much more thorough. If you're in an emergency room situation, there could be things around standardized protocol, including taking photos of violent, injuries, So the assessment really is going to look different depending on your scenario and your particular healthcare setting. Intervention, and this is again going to look a bit differently. On the intervention, things should be at a minimum affirming the individual's bravery and inherent self-worth. It takes a lot of courage to disclose these kinds of situations, and being a victim of interpersonal violence and intimate partner violence. So you want to make them feel heard and safe and reassured, and again, really emphasizing their inherent self-worth, which most often, if a person has been a victim of this, they've been questioning their inherent self-worth. That is part of intimate partner violence and domestic violence, is kind of that psychological damaging to the individual. Reassure them about confidentiality, specifically from other people in their family and the potential perpetrator. Letting them know that nobody else can access their medical record without their consent. That within larger electronic health systems, there are certain protocols for keeping certain types of information safe. You'll have to explain whatever those protocols are for your electronic health record. You also want to remind them about limits to confidentiality. And I'll talk a little bit more about that in a second. Intervention also can look like safety planning. So connecting to resources, connecting them to other services, and depending on what type of healthcare provider you are, discussing things like invisible birth control options, if that's applicable to the individual. So under the limits to confidentiality, and this is where it's a little bit different than maybe my training was, but I was trained to work initially in outpatient mental health, or even when I was in inpatient mental health, I was really on the mental health side. So for your average adult, you're not breaching confidentiality for an offense that's been committed against them. So if a woman comes in or a man comes in and they disclose that their partner had beat them up, there's lots of discussion that would happen, but there would be no cause for me to breach confidentiality. If they wanted me to help connect them to resources, then that's fine. But like I said, upon further digging into this, if one were working in an emergency room setting, but possibly primary care or OB-GYN, you might be the first person to see a significant injury. And under the Ohio Revised Code, anybody who's giving aid to somebody who was injured in what would be considered a felonious manner must report that to police. So this is if a person comes in and they were shot, if they were stabbed, or if they experienced some type of significant burn injury. So in those cases, whoever is treating that person must report that to the police. Now, that said, healthcare providers are not required to break confidentiality, and absolutely should not without the patient's explicit request to do so, unless it's a minor, obviously, elderly, an adult who is developmentally disabled, so would be considered a vulnerable population, or potentially somebody who's under a guardianship for whatever reason, or if the above criteria are met. So there are times that you are required to breach confidentiality, but there are definitely a lot more scenarios where you're absolutely not required and definitely should not do so. The other piece of intervention, though, is helping connect to resources. And here's 2 websites and phone numbers to help people connect to either an immediate chat line or to find a local domestic violence program. There's people from all kinds of communities that join this program, so I didn't want to try to get into county level resources. I know my county's resources. I implore each of you to figure out what your county's resources are. And the last piece of this is on documentation. So there is rule within the Ohio Revised Code, as noted here too, that any physical evidence of abuse should be documented in a person's health record. And that if there's any belief, and it lists the full gamut of professions that might work with people who might find out about abuse, if there's reasonable belief that a person is a victim of domestic violence, we are required to note that in their record in some fashion under the Ohio Revised Code. And in my reading through this, my understanding is that because if they do eventually decide to leave and they decide to press charges against the person, our records could be utilized in their defense and kind of in the legal proceedings if that were necessary to support their case. So here are the official citations that I used. Again, the Ohio Domestic Violence Protocol for Healthcare Providers, the standards of care is posted to IECHO. You can find it a number of places on the internet, so I listed just two. Actually, it is under two because you can find it not only at the first link, but you can also find it on the Ohio Domestic Violence Network's Resource Center. I did tap into the 2024 stats around domestic violence, and there's the direct link to the power and control wheel if you'd like to see that a little bit better. I know that the picture on the screen is a little bit blurry, but it is found in the appendix of the standards of care also.